Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why.
Good evening,
And
everyone.
welcome to, sorry, Dr. Kane. Good evening and welcome to Pause for the Truth. I am Jocelyn Turner. You caught me off guard, Dr. Kane, because I am troubleshooting with our other guests. Um,
Okay.
how are you doing this evening?
I'm making it. Look at I'm just like uh, uh James Bond Martini, broken and stirred, but that's about it.
That sounds like a story that I am not familiar with. Sorry.
Don't worry about it.
Joining us this evening is Dr. Christopher Williams. How are you doing, Dr. Williams?
I am well. Thank you for having me again.
Are you kidding me? When we talk about prostate cancer, we have to have you as a part of the conversation.
Well, I'm happy to participate.
And I am going to let Dr. Kane take over for a moment while I work with Tyrone, our behind the scenes guy, to get our other guest on. So, Dr. Kane,
Okay,
if you would take it away, please.
gotcha. Hey, Dr. Williams, once again, hello. Thank you for coming to the show. As Ms. Turner said, when we're talking about prostate cancer, in fact, any urological cancer, we have our own national expert in the studio at all, on speed dial, which is Dr. Williams. Um, Both a national and a personal expert from my standpoint. I'm no shame in my game. Dr. Williams is my urologist, and he's taking very good care of me. And I would advocate to anyone for the utilization of his services. And again, Dr. Williams, tell him what your specialty is, because you can do it much better than I do.
Okay, well, my specialty is urological oncology. So I'm a urologist, but I'm specially trained in taking care of cancers of the urinary system. So after my 6 years of urologic and surgical training, I went to the National Cancer Institute at the National Institutes of Health in Bethesda, Maryland, and did a 2 year fellowship in urological oncology. And then from there, I was recruited down here to University of Florida here in Jacksonville, where I was there on faculty for 14 years approximately. And then I took off about 4.5 years ago and started my own practice called Urology Consultants. And I don't do the major cases anymore where I take out the kidneys and the bladders and the prostates, all those kinds of things. Now I do a lot of consultant work. So people who are newly diagnosed with cancers or need to be screened properly for urological cancers, I can do that for them and give them instructions and feedback on what treatment options and just how to proceed. And so I really enjoy doing that because I found that there's a dearth of education in the community. And I love to educate people because knowledge is power. And I see that firsthand every day when I'm talking to patients when they come in kind of down and out when they've been diagnosed with a urological malignancy. And it's a lot of it, it's just fear because they don't know what next to expect. And I can kind of inform them on what our plan is. We get a good game plan and we leave the office with some smiles a lot of times. That makes me feel
And
good.
and again, his consultant services are quite helpful, even though he may not be the one to perform the surgery, as he himself said. His consultation is invaluable. To the point I've had some relatives come up from South Florida to utilize his services. So, like I said, no shame in this game in terms of utilizing Dr. Williams. I may be pimping him or something. Maybe that's what he think I am.
Don't say it like that. I don't think
No.
Dr. Williams want to be thought of in that man. Dr.
Well,
Williams,
I know he does, but
I have a
we're
question.
just joking. Go
Yeah,
ahead.
I have a question for you, Dr. Williams, because I was having a conversation with someone earlier. And do you find that, and this is for both of you actually, do you find that some men need that extra nudge from the female in their life? They don't like necessarily going into the doctor, because someone was telling me about their man, and a new man, I should say, and that they had to give them that nudge and say, just have the frank conversations. Have you been to the doctor lately? Are you getting, do you know your numbers, for example? And so I wanted to ask you this. It was just real relevant for this discussion.
Well, I mean, people get referred to me a lot, for
Okay,
different reasons, and many times they come in with their significant other
gotcha.
already, and I
Hmm.
don't, in that context, I don't know if it was her who prompted him to come, but it's
Gotcha.
always good to have her with him because many times she can fill in some of the historical gaps, and also many times the man is kind of hesitant to bring up certain discussions. And
Hmm.
to my surprise, it's her, the one who brings up and starts asking about erectile dysfunction and things of that sort when he kind of, is afraid to start to bring it up. And
Yeah.
that surprises me a lot of times. It's the lady who says, "Hey, what about ED? Help us."
Right.
And that's actually refreshing, to have them as a team, seeking assistance rather than him just kind of being out there on his own, because sometimes it can be a little embarrassing. But when she's there with him and kind of prompting him, and helping him to know that she's interested as well, and it's for them both, that's a good thing.
But
Yeah, being on the front.
even in front of the doctor, he's embarrassed to say, "I'm having these issues." Really?
Absolutely,
Yeah,
absolutely, and it's not just like with erectile dysfunction, even with cancer related stuff. There many men are like often ashamed as if they did something wrong because they're at risk, and there's nothing to be ashamed about. It's life. It's a was it 1 in 6 men were diagnosed with prostate cancer in our community, and that's a big number. And so it's very common. And the more we talk about it, and we shouldn't have to use the phrase normalize it because it is normal. It's that common. But the more we talk about it, then the more people become comfortable talking about it. And that's what
Mhm.
we need. We need more
Mhm.
dialogue. We need it to be talked about, in everyday conversation. And then more people can be saved.
well, Ms. Turner, being on the front line in primary care, most of the time we are the ones that screen them before Dr. Williams lay his hands on them. We hope to be at least, and one of the reasons is because if it's done through primary care initially, there's a good chance it might be early enough that he can work his magic, getting time to make sure that you can survive not only prostate cancer, but get as much to, speaking of normalcy, much to as normal life as possible. And I'm from the old days when Viagra was one of those secret words that you couldn't say Viagra, you had to say vitamin V or something like that. Way back when, and I've encouraged women to go and address their mate about it to make sure that they're looking into the possibilities of what's going on with them from their prostate standpoint. Because, and I don't want to say admonish to men, but I let them know that they're not the only one in this fight. Because if something happens to them, then their family has to suffer. And one of the first things they'll say is, "Well,
Mhm.
Dr. Kane, you got to die from something." And I hear that quite a bit. So
Mhm.
yeah, but the problem is you might not die. You might just be left crippled, or someone's got to lay in bed with you roll you over in bed and clean you up, all because you were too ashamed to admit to your frailty. Your family should not.
Mhm.
I'm saying when I say frailty, I'm talking about as man anyway. We're all frail in
Right.
terms of not being superhuman and not thinking, not realizing that we're vulnerable to to what Mother Nature has, the adverse effects emerging at Mother Nature, i.e., cancer. I guess I'm just
Mhm.
speaking to that issue. But
So
yeah,
what
I encourage
symptoms?
women. Period.
What symptoms do men tend to start having to indicate? And I know it's not always symptomatic, by the way, because when my dad was diagnosed, if he had symptoms, let's put it that way, he didn't mention it just from getting a routine, his annual PSA test. His primary care physician noticed that his numbers increased from the previous year. So what are the general symptoms that may alert men that something is they need to get checked out?
Yeah, I really try to push people away from thinking about symptoms, because prostate cancer is one of those things. It's almost like high blood pressure. It's doing a lot. It can be doing a lot of damage before you ever have any symptoms. And in prostate cancer situation, if you're having symptoms of prostate cancer, sometimes that indicates metastatic disease or locally advanced disease, something that can't be cured. So we don't want people to say, hey, I'm not having any symptoms, I feel fine. No, we don't care about symptoms. We want you to get screened. We want you to get your PSA checked. I want people to get their prostates checked, your finger in the bottom, to feel the rectal exam, make sure their prostate feels okay. Because sometimes you can have a normal PSA and have an abnormal rectal exam. And I detect prostate cancers like that often. And so I want people to just be in the habit of going to get checked, knowing that they are at risk. And because they are at risk, go to get screened, just like women, you have breasts. So that means you're at risk for breast cancer. So go get checked. Men, you have a prostate. That means you're at risk for prostate cancer. It's the leading cancer diagnosed in men. Go get checked because you may have it.
While we at it, since we mentioned breasts, I just want to make sure men also know they need to check their breast. There is a 1%.
That's right.
1 in every 100 cases of breast cancer may be a man. And even though that may not sound like a lot, it still can get you. So also check your breast while you're at it.
Well, while you're at that, though, let me mention too, though, because people who have family histories of breast cancer, then the men in those families often are at risk for having more aggressive prostate cancers. So a lot of times you can have, breast, colorectal, ovarian, all of those different, and prostate cancer and pancreatic cancer. If you have family histories of those types of cancers, especially being diagnosed at early ages, then that increases your risk of having one of the other cancers too. So, your primary care doctor, would be the one who would kind of link all of that up and say, hey, wait a minute, if you got this, then we need to check all these other things and get you properly screened for those other things as well.
Dr. Williams, you messed me up recently, by the way, when you told me that, because just to our audience, I shared with Dr. Williams, and we were talking about the diseases that you inherit from your family members. And when my dad got a prostate cancer diagnosis, I said, well, Dad, that's one disease I don't have to worry about getting because I don't have a prostate as a woman. And Dr. Williams was like, well, hold up. Well, now, you do have your parents' genes, right? So that whole genetic relationship or connection, because my dad had prostate cancer, I am now at a greater risk of developing breast cancer. That messed me up, Dr. Williams, when you said that.
Yeah, I mean, because there, and especially with aggressive prostate cancers, many times those people have the BRCA mutation with breast cancer as well, and that can portend to a more aggressive behavior of prostate cancer. So, like I said, we're starting to learn more about the genetic linkages, and so if somebody has these cancers that I mentioned, especially diagnosed at an early age, or if they're very aggressive or advanced, then it might mean that there's a genetic predisposition involved. And so genetic testing is recommended.
Gotcha. So joining us, welcome AJ Merriweather. How are you this evening?
I'm doing fine. A little technical problem, but other than that, we got it to work.
We know that Carl Tyrone was going to, our behind the scenes guy was going to get you in. He's going to troubleshoot and make sure. So I can tell our audience, I met AJ because he is such a huge advocate for educating the community about prostate cancer. How are you doing this evening, AJ? Everything going okay? And tell us how you got involved in becoming an advocate and educator about prostate cancer.
Thank you for allowing me, Ms. Turner, to join you and Dr. Williams this evening. I got started in 2011, diagnosed with prostate cancer. Didn't know nobody who had prostate cancer. That was in 2011. When I got it, I'm like a typical people that get the word cancer. You get shot and you think you're gonna die. And one of the things I did when I got diagnosed, not knowing nobody in my family or anyone in my community, after getting the diagnosis and the treatment, I started a support group in my neighborhood on a Sunday, just with my neighbors. And every Sunday we would meet at my house, and I just started sharing with them my journey, and not wanting my neighbors to go through what I went through. And by partnering with Dr. Odetna from UF at that time, she was able to give me some educational training back in 2014. And from then on, I just became a one-man show, I call it. I just went to churches, health fairs, and I joined different support groups that I started myself called Black Men Prostate Cancer Coalition of Florida. And I just started that. And from that, just going around the state, promoting it with materials and just telling my story on how I have a family, as Dr. Williams was just saying, I got a family history. And one of the things we didn't know, Dr. Williams, was when I got diagnosed, I got an older brother, 3 years older, and we both got diagnosed the same time, same doctors, same clinic, but we never talked about it until we had a gathering at my house for a Christmas dinner. And we both said to my mom, I got something to tell you. And I said, Mom, I got something to tell you. And bottom line, Doc, we said, I got prostate cancer. My brother said he got prostate cancer. And my mom said, what's the chances that I got two sons that got diagnosed at the same time? And the part, Miss Turner, that's really strange is we didn't tell each other. And I was going to the same doctor he was going to. I was going in the morning and he was going in the evening. And the part was, Johnson, the part that was strange was that Privacy Act thing that we have at these clinics. They knew that my brother was there, but they couldn't tell me that he was going for treatment. And it was just, one of those things. So basically, I became an advocate and I just educated myself on the journey. And Dr. Williams, as you was talking earlier about the bracket gene, it's like I got it. I got an older brother who got enlarged prostate. I had a nephew this year got diagnosed with prostate cancer and bladder cancer. I got a niece that just finished her breast cancer treatment. Got another sister that's got maybe breast cancer. So we got, as you say, that gene is in there. And that's one of the things that I try to tell people, get that genetic testing so you can know if you got a family history and then know your history. It's one thing to say, I know my mama got this and I know my mama got that, but I got a family that I can track. It's 4 siblings, and out of the 4 siblings, each one of the siblings got a child that done had some type of cancer.
Yeah. Well, like you said, though, that the important thing is like, what do you do with the genetic information? Well, that information is so that you can pass on the information so that you can start to get screened earlier, because you're no longer considered average risk. You're considered high risk. And because of your high risk nature, then you need to be getting screened earlier than the average risk patients. And so that's the thing. The whole point is to try to catch something earlier. We're not where we can prevent a lot of these things because they're genetic sometimes and they get passed along. But the earlier you can catch it, then the sooner you can start to treat it.
I'm glad you said that, Dr. Williams, because I've heard people say that, well, I don't want to get tested. Why? They can't do anything about it. They can't stop me. But the importance of what you said is when it comes to cancer, early detection is the best treatment for it, because if you find out early, then I know that's what happened with my dad. They said his was detected early, so his prognosis was good. Sadly, he just died of lung cancer. Before we continue the discussion, because I definitely want to continue, a couple of months ago, we started featuring African American history makers. We'd like to pause for a minute and tell you about our African American history maker this week. Tyrone, take it away.
And welcome to Pause for the Truth's History Makers, Minute October 17th, 2023. As we reflect on the past and present, it is important to recognize the people who have made significant contributions to America and the rest of the world. Today we present Dr. Lewis W. Sullivan. born November 3, 1933. Federal Cabinet appointee and college president Dr. Lewis Wade Sullivan was born on November 3, 1933, in Atlanta, Georgia, to Luberta Priester and Walter Wade Sullivan. After graduating from Booker T. Washington High School, Sullivan received his B.S. degree in biology in 1954 from Morehouse College. He received his M.D. degree in 1958 from Boston University School of Medicine, completing his residency 2 years later at New York Hospital Cornell Medical Center. In 1960, Sullivan began a one-year pathology fellowship at Massachusetts General Hospital in Boston, before working at Boston City Hospital and studying hematology at Harvard Medical School's Thorndike Memorial Laboratory until 1963. He was hired as co-director of hematology at Boston University Medical Center in 1966, and he founded the Boston University Hematology Service in 1967. In 1975, the Morehouse College Medical Education Program was founded and Sullivan returned to Atlanta to serve as its first dean and director. The program became the School of Medicine at Morehouse College in 1978. In 1981, the school became independent and was renamed Morehouse School of Medicine, MSM, the only predominantly black medical school in the United States established in the 20th century, with Sullivan serving as its founding president and dean. In 1989, Sullivan left MSM to accept an appointment from President George H. W. Bush to serve as Secretary of the United States Department of Health and Human Services. Sullivan returned to MSM in 1993 as president, becoming President Emeritus in 2002. In 1976, Sullivan became the founding president of the Association of Minority Health Professions Schools and, in 1985, he became one of the founders of medical education for South African blacks, serving as chairman from 1994 to 2007. From 2001 until 2006, he served as co-chair of the White House Commission on HIV and AIDS. In 2003, he was appointed chair of the Advisory Committee of the White House Initiative on Historically Black Colleges and Universities. Sullivan also has served as co-chairman of the Henry Schein Cares Foundation, chairman of the Washington, D.C. based Sullivan Alliance to Transform the Health Professions, now a central program of the Association of Academic Health Centers, AAHC, and on the boards of 3M, United Therapeutics, Emergent Biosolutions, General Motors, Cigna, Bristol-Myers Squibb, and Equifax. He was the 2008 recipient of the Jimmy and Rosalind Carter Award for Humanitarian Contributions to the Health of Humankind from the National Foundation for Infectious Disease. Sullivan is the author of The Morehouse Mystique, Becoming a Doctor at the Nation's Newest African American Medical School, with Marybeth Gassman, 2012. His autobiography, Breaking Ground, My Life in Medicine, with David Chonoff, 2014, won the NAACP Image Award for Literature in 2015. Hello and welcome. Hello and welcome.
Wow, and I might add this Black History moment. Dr. Kane was in the first class at Morehouse School of Medicine. Am I correct? Dr. Kane?
Rogers O'Kane. Yeah, I happen to be at that 1985 class that they made reference to. You heard them say 1981 when they fully became a 4-year school, and that gave you 4 years later. That's 1985. I entered Morehouse in 1981 and exited in 1985. So I am one of the, and I know Dr. Sullivan well, had multiple encounters and discussions with Dr. Sullivan. So, yeah, just proud to say I'm still one of those historically Black schools graduates, along with my initial alma mater, Florida A&M University. So, yes.
So we can include you in this week's African American History Makers. Congratulations on being that first, Dr. Kane. Always learning from these moments that we pause for our African American history moment. Thank you, Tyrone, for sharing that with our audience. If you're just joining us, we're talking about Black men and prostate cancer. If you know, last week we talked about Black women and breast cancer. And we felt it was important to continue the discussion because as we paused for, right before we paused for the history, African American history moment, we were talking about the genetic connection in our families. AJ Merriweather, who's joining us, a advocate, champion, all the words when it comes to educating the public about prostate cancer because of his own personal journey, and Dr. Christopher Williams, and hopefully I'll say this right, a urological oncologist.
Correct.
Um, and so to have both of them here to share their knowledge and experience. AJ, I can only imagine, one of our guests last week talked about her family history and making the decision to have a double mastectomy, knowing her risk. She just did not want to go through that. I can only imagine how your family, how you and your brother felt when you found out you were going to the same doctor and diagnosed on the same day, but how the irony of it, one of you are in the morning and one of you in the afternoon, and the practice knew. Dr. Williams, at some point it would seem that, I know HIPAA is something, but my goodness, what is wrong with that picture?
Well, that you can't blame the doctor for that. What the doctor should do, though, is encourage them to talk.
Yeah.
Say, hey, because because the doctor would have asked, do you have any family history of prostate cancer? And if you don't, then you should at least let your siblings know that you have it so that they know that they are at risk. Their risk is 3 to 5 times higher now because you have it. And then that would have sparked the discussion between the two brothers. That's the way it should have worked. But from a HIPAA standpoint, the doctor cannot say anything.
Do a thing. Well, thankfully, they cared about their mother enough to each share what was going on with them, because just imagine if they had not cared enough to share with their mother at that moment.
Well, unfortunately, that is not all that strange. I have some really close friends, and he was diagnosed with prostate cancer and then found out he had an older brother who had already been treated for prostate cancer and didn't tell anybody. So then he could have gotten screened earlier. And then it turned out that he had locally advanced disease, and because if he had known that his brother had been diagnosed and had aggressive disease, then he could have been screened sooner and maybe he could have been caught earlier. So he didn't have to have, surgery and radiation. And now he's, close monitoring and hormone deprivation, so many different things. So that story is not as unusual as you think, unfortunately.
And I've actually seen that. I don't know if we're talking about the same patient, Dr. Williams, but I've seen the same thing happen in our practice. With a brother not telling the other brother, and I've seen it.
But one of the Jocelyn, can I interject a comment to? Good to see you, Dr. King. If you don't remember me, you came to the post.
Oh, I remember you.
Yeah, but you came to the post when we had the program. One of the things I want to tell both of y'all doctors is when I'm an advocate. I'm a PI for Dr. Odetna and the Mayo Eye Care Consortium. And why am I telling you that? Because one of the things as an advocate, you have to Ms. Turner know this. You have to educate yourself and partner with other organizations to learn more. They always say early detection saves lives. I say early learning saves lives, because if you can get involved with an organization, I've been with Dr. Odetna since 2014. For the panel, I'm the ambassador for Florida for Prostate Health Education of FIN, which is Tom Farrington. I represent the state of Florida for FIN, and I represent Mayo as the ambassador and a PI on their grants. But what I want to say to the doctors is, what I tell guys now, they'll come to me and say, Brother Merriweather, can you go with me? And I go to some of the doctors, and I know them now, and they know me from my work in the street. And, I tell the doctors, and I'm going to tell you, Dr. Kane, keep it simple. When they start talking all that technology and all that technical, those guys look at me and say, Mr. Merriweather, what are they talking about? And I got a good rapport with the doctor. So I say, hey, doc, you tell me, and then I translate it to the street language. But one of the things I learned being an advocate is people trust when you say, I know what you're going through, that means a lot. If you done been through, it's a different when you say, I know what you're going through. Well, have you had prostate cancer? I heard Jocelyn say about her father with lung cancer. I tell people, once you get one cancer, you're subject to get another one. And I'm a witness because I had stage 3 lung cancer in 2019, was only given 2 years to live. I'm on my 4th year. And one of the things I learned by being out there as an advocate is once you get one cancer, it's depending on your family history, as Dr. Williams say, the genetics and the genes and all this. And I was told by one of y'all colleagues, Dr. Yates, used to be at, I guess Dr. Yates used to be at Tuskegee. He was one of the early doctors that discovered that BRCA gene that was only in black men. And now he's up there in Johns Hopkins. But my point to it, he told me when we was at a conference last week, he said, Mr. Merriweather, I want you to do some genetic testing for me because you got a family history and you got a story to tell. And what I want to say, Jocelyn, is I done had prostate cancer, I done had lung cancer, but you know, we got the best doctor in the world, gentlemen. He got all the cure. If it was my time to go, I would have went. But what I would like to tell the panel is this, sir. When we first get diagnosed, y'all know from y'all patients, we be scared. But it's nothing wrong with being scared. What is good about being scared is if you got somebody being honest with you and telling you the truth about your diagnosis. And it's one of the things I found when I was dealing with doctors that didn't look like me, didn't talk like me, was I spent more time with the intake, Jocelyn, than I did with the doctor. So I tell guys now, if you spend more time with the intake person than the doctor, reschedule. They say, well, why you say that? I say, because when you're making a decision about your treatment and your health, you can't do it in 5 or 10 minutes. First of all, you got to go home and pray about it, as far as I'm concerned. And then you got to do your homework. What's my diagnosis? How long is it going to come back? What's the chances of being successful treating? Is it radiation? Is it watchful waiting? Is it proton therapy? Is it RT? All those good things that nobody know on the street about unless you take that class. So to the panel, just remember, when you get the newly diagnosed person, you know the education. They come into you to talk straight talk, as you say, just straight talk and the truth.
Let me interrupt. Let me interject, Dr. Johnson. He's absolutely correct in terms of your doctor doesn't need to walk in the room and say, "Hey, you got cancer," and then turn around and walk out. You know, and most of the time, you know, and I'm not being anti anything, but most of the time when they do look like you, you do tend to get more a greater understanding in terms of taking time for the proper dialogue to communicate with that patient. And, you know, even though I kidded Chris not long ago about our situation, I still will say, you know, he does take the time out, much like, and I'm not doing a pat on the back, much like I do, we will take the time out. You know, you put that clipboard down, you put that the computer down, and you talk to those patients and give them a chance to voice to you what their concerns are. Explain it to the best of your ability to that individual and or their family, and then people can help make the right decisions for themselves. I don't have patients coming out of office for me to tell them what to do. I do like to inform them. If they ask for my opinion, I give it to them if when asked or needed. To be honest with you, I will provide it to them, but I also make sure that they go and talk to that individual, such as the specialist, as Dr. Williams is. And if they tell me they don't, you know, he didn't say anything to them, we may seek to look and get help somewhere else to somebody who better understand and appreciate that person's position.
If you're just joining us, thank you, Dr. Kane. Thank you, AJ. If you're just joining us, we're talking about Black men and prostate cancer. The conversation is good. And, you know, I think as Dr. Williams, as AJ, Dr. Kane has said, what I get the most from this is we've got to start having a conversation with one another about what's going on. And as Dr. Williams said, not to be ashamed to talk about it, right? You don't have to tell everything that's happening with you in terms of if you're experiencing ED or you're going frequently to the bathroom, but just tell your loved ones about your diagnoses, right? So that they then can start going in and getting screened at an earlier time than perhaps normal for their age because of the strong family history. AJ, all of you know, over the years, we were doing a health summit for men and boys called Man Up for Health.
Mm-hmm.
On some years, the attendance was excellent. And those were the years, quite frankly, where we had a celebrity guest. They won't come and see the celebrity of Dr. Williams and Dr. Kane and AJ. They're coming to see the celebrity ball players, right?
Yeah.
Why is it that it's so hard for people to be so dismissive when it comes to men? I'm not going to say people because ladies will show up, right? But why does it take coercing men or using a ball player to attract men to come to an event about their health, or it takes a diagnosis that make them want to be a champion for health? Why aren't men rather so more proactive when it comes to their health? Anybody?
One of the things is, Jocelyn, you men from working at the American Legion Post, working with different organizations, what we found out is when you have someone looks like you that's got diagnosed, it really is not a celebrity. If you got a story to tell, and my story, Jocelyn, I've been with you when you was at the state, when you was on university and all that, and you done seen me at health fair. One of the things, Doc, that I think is that's important is when you have someone that done had the disease and can talk frank, going to the bathroom, Peyronie's disease, all this stuff. I when I speak to the churches and me and group, I don't sugarcoat it. I just tell it like it is. And one of the things I found out is when I tell the story and I tell why I became an advocate, I have more guys saying, Mr. Merriweather, how can I get in touch with you? How can I get you to come talk? You get all these sports. Every now and then you get an Al Roker or somebody. Jocelyn, if you remember 2 weeks ago, I said, God don't like ugliness, and I forgive me, audience. I'm just saying the gentleman that on the city council that he got prostate cancer, and I say, look at God. He probably didn't pay attention. Young man in his 40s, but he didn't pay attention to his health warnings. And then he was a news flash. I got prostate cancer. First thing I said was, how many times you done heard about prostate cancer out in the community and you didn't pay it no attention? Then when you get it, the old saying, Dr. William, woe with me, what I'm going to do now. But you had warning sign, early detection. You my question when I seen it on TV was, did he know the warning signs? Did he not know going to the bathroom a couple of times at night and then stopping, going, all that other stuff that we experienced? But I thank God that he did get diagnosed and he's getting the treatment. But maybe that could have been caught early. He's in his 40s and got this.
Well, Mr. Merriweather, I think before you got on, one thing I was telling Jocelyn about is that I like to push back on the warning sign things because sometimes that's what keep people from coming to get screened. They say, well, I don't feel anything. I feel fine. And the point is, you should not feel anything. Most of the symptoms that you mentioned are not prostate cancer symptoms. Those are symptoms from enlarged prostate, which has nothing to do with prostate cancer. So many times people are waiting around saying, well, I'm peeing fine. I don't have the symptoms that you talked about, so I don't need to get screened. But the point is, if you're having symptoms that are attributable to prostate cancer, those are not symptoms of BPH typically. Those are symptoms from metastatic disease, bone pain, weight loss, those kinds of things. And so I want people to just get screened because they are at risk, because they're African American, because they have family histories of prostate cancer, because they are men. That's why they need to get screened. And I don't want them to wait for any kind of symptoms, because usually when you have symptoms that are truly attributable to prostate cancer, it's from metastatic disease that's not curable.
And I'd
BPH
like
is one
to
of those
mention,
scientific terms, or at least acronyms for enlarged prostate. For those non-physician listening, he's talking about enlarged prostate, and I agree with Dr. Williams. You know, having symptoms of an enlarged prostate is not necessarily diagnostic, and or do you want to wait on symptoms before trying to detect, before looking for prostate cancer? Because we've seen prostate cancer in somebody with a very small prostate and have absolutely no symptoms whatsoever. And then we've also seen no prostate cancer in somebody who's had huge prostate that we've had to, they become obstructed in terms of their urine flow, and we've actually had to use a catheter just to allow them to pee. They are two different things.
Yeah.
And if you're waiting for symptoms to show up, you know, you may be waiting a little bit too long and allowed it to spread away from that prostate, or from an area where it can be easily treated, to more of a like even within the area of, you know, where the prostate is at, it can extend by direct extension, which they just, you know, it just spreads by growth only, just opposed to piece of it breaks off, or cells break off, go to the brain, go to the spine, go to the liver, you name it. You know, you don't want to wait on those symptoms before you decide to go look for prostate cancer.
so I'd like to share a few statistics, by the way, for our audience. Every 13 minutes, a Black man is diagnosed with prostate cancer. 1 in 6 Black men will be diagnosed with prostate cancer in their lifetime. So just think about that. There are 3 men on this panel. If there were 6, 1 in 6, which that one is already AJ, right? Every day, nearly 17 Black men die of prostate cancer. Again, think of 17 men that you know. Of the 17 men that you know, 1 of them may likely die of prostate cancer. 33% of Black men 50 or older had a PSA test in 2018 compared to 37% of white men. So we need to increase the number of Black men that go in for PSA screenings. Today, there are 3.1 plus million prostate cancer survivors. AJ is one of them. Black men are 1.7 times more likely to be diagnosed with and 2.1% times more likely to die from prostate cancer than white men. About 41,600 Black men were expected to be diagnosed with prostate cancer. The good news, if caught early, more than 99% of people diagnosed with prostate cancer will be alive in 5 years. I don't know about you, but if I know that if I simply start a regular routine of going to the doctor, getting checked, getting a prostate specific antigen or PSA, and getting the dreaded digital rectal exam. I'm going to call it
Don't feel the finger.
Look, you didn't see me, but I had my fingers like this, right? The dreaded digital rectal exam, that few seconds of discomfort can save a whole lot more of discomfort if only you go in. I was happy when I went in with my dad to his urological oncologist at the time. I didn't know Dr. Williams, but I think it was, anyway, I won't call his name, not to promote another doctor. But when he said to my dad that, Mr. Turner, your prognosis is good because you were diagnosed early. And so, you know, and he went through his treatment. He actually did the radiation seed implant. And so that was all weird to me, by the way. And Dr. Williams, if you only know how, you know, having these conversations as my dad, as a daughter, about your dad's issues, at some point you just have to get the embarrassment out of the window, right? And realizing this is my dad, whatever I can do to be here and have this conversation and be his advocate and champion and what have you, I'm going to be that person. So we gotta have conversations. I tell people, when you're planning your family reunions, the next time you go for your family reunion, write names of diseases next to each family member on that tree. because there are some families that have rare diseases in their families, so that the future children, current and future children, will be able, once they start having some symptoms, they'll be able to share, hey, I had diabetes, I had whatever, cancer. If you're just joining us, we're talking about Black men and prostate cancer. It is a diagnosis, unfortunately, that happens far too often. But if you simply go in for routine prostate exams, know your numbers, not only your blood pressure and your weight, because so many people keep up with those numbers, but know your cholesterol, your blood sugar, and for men, your PSA levels. Dr. Kane, do you have a question of our guests?
No. I'm actually just gonna let people know that I was participatory in your dad's care, and you asked a lot of questions at that time, and as you said, and we just discussed, get over that, the embarrassment part, because we understand. You hate to, just like it was me and my mom. I had to go and take care of some of those issues that are very personal that never would have came up when mom could do it for themselves.
Right.
I will step forward and do what I got to do, and I'm not embarrassed about it, and try to make sure she's not embarrassed. And we, you and I had the conversation the same way with your dad. We're not embarrassed about it, and he had the conversation with you and let you know I'm not embarrassed about it. So he trusted me with his care just like you did. And but it was all about conversation. We talked.
Absolutely. AJ, tell us a little bit about what you're doing. You mentioned about the post. Can you share what you're doing there?
Yeah, I'm with Dr. Odetna from the Mayo. You remember, Jocelyn, your audience might not know what ICARE stands for. Established for Inclusive Cancer Care and Research Equity for Black Men's Consortium. What we doing at the Post, we partner with Dr. Odetna and the Mayo Cancer Center, and we made the American Legion Post, which, if for your audience, Dr. Kane, you one of them old dogs, so when we say we go into the Post, you ain't got to say Post 197. You just say Post, Dr. Williams. You ain't smiling, so that means you ain't been over to the Post yet.
It used to be the club, but go ahead.
But what we doing over there, Dr. Williams, is we made partner with Dr. Odetna and Mayo. We made that an inner city hub for clinical trials and research. And Mayo, typically don't come into our community, but they want to get in our community. And by having a Black doctor that's prostate advocate globally, she's putting resources in. So one of the things, Jocelyn, you asked me what we're doing is we are focusing on bringing programs. Dr. Kane came to, him and another doctor came to one of our programs. What we're trying to do in that 06, 07 area is made Post an inner city hub. Everybody know it as a club, but now we're a resource center where you can come off the street, use our computers, use the printers, do research, use our kiosk machines. We got cameras. And one of the great things we are doing now is come January, I had a support group before COVID hit. FIN, Prostate Health Educational Network, was sponsoring it. Now we got Mayo sponsor support group, and Dr. Williams, for the newly diagnosed people, if you go across the bridge, they got a support group. If you come across this side of the bridge and try to find a support group, you ain't gonna find one in our neighborhood. So what we doing at the American Legion, starting in second Saturday in January, we're going to have a monthly support group for the men. We're going to promote it, Jocelyn, where they can come out and have doctors such as Dr. Kane, I hope, and Dr. Williams to come out and speak to the veterans and the men in the community about prostate cancer. Because one thing, Jocelyn, that you didn't hit on, we in a health desert. And that's one of the things, as I listen to the two gentlemen talk, one of the things we have to be understanding, docs, is a lot of people ain't got insurance. A lot of people scared to go to the doctor, and we are trying to address that at the Post by saying we're going to give you resources. We're not going to give doctors information, but we're going to give you resources, contact. We're going to have different speakers to come and talk about it. And I'm looking forward to the American Legion taking the next step to be a support group for that neighbor, for the north side, to be able to say, men, come out. Let's have that conversation where it's just men talking about prostate cancer, having the experts to talk about it. And that's the most important thing that I'm doing now, besides doing I'm the global ambassador for Mayo for advocacy. One of the things Dr. Denton has me traveling around the country is promoting advocacy and grassroots training, just talking to guys and telling them how to talk to guys about prostate cancer. And I think you know, we always say the women veterans say, why y'all talk about prostate cancer? Because we don't have no prostate. So, you know, for you to have this conversation with three gentlemen and you can be just as open, thank you.
Let me say this, Ms. Turner, before we get off. I want to make sure, and I appreciate that, Mr. Merriweather. We use all hands-on deck model in terms of trying to address cancer and disease in our community. So all hands on deck. But what I do want to make sure also that we recognize that are people that are in the communities, such as myself. I'm actually in that health desert. People that have been serving a health desert, like Dr. Christopher Williams, is out in that community. We've been there for a long time, and we want to make sure that there are people out there that look like you, that walks amongst you, and that are very much advocates within our community for the proper health care. Dr. Williams, we're getting short on time, but I wanted to make sure that if there's, I'm participatory, and you can explain it without me blowing your cover or whatever, speaking for you. I'm a participatory in one of those clinical research programs as well, and I'm letting you out there free to speak to that particular clinical research project.
Yeah. Well, what he's talking about is, so when we're trying to make a decision about whether to biopsy somebody, one of the things that we can incorporate are genomic tests. So there's blood or urine that looks for genes that are associated with aggressive prostate cancer behavior, because if you have those at a certain amount, then that might push us more toward doing a biopsy. Whereas if you don't, we might not do a biopsy. We may wait, see if the PSA continues to rise, so on and so forth, because not everybody needs a biopsy. And we really want to diagnose prostate cancers that are more likely to be clinically significant. I don't really like that word, but that's the word they use. But they're more likely to cause people problems, die, cause them to have, spread, things of that sort, and not be diagnosing the ones that we're just going to watch anyway. And so by doing that, then we can not diagnose so many prostate cancers and put people through the discomfort of the biopsies and so on and so forth. And so there are a lot of different genes or biomarker tests that you can use. And one problem that we have many times with such tests is that when they've been through the process of being evaluated, then all the patients who've been used to do these evaluation tests on don't look like us. And so the question is, well, do these tests then, are they relatable to us? Do they give the same information, because they really weren't tested with us in mind? And so I try to employ the use of those tests as much as possible, so that then they have Black people in a database, that they can, we can make sure that because now more Black people were used to evaluate the test, then we can determine if they are as relatable to us as to the general population. And so I just try to use those tests all the time. I employ several different tests before biopsy. I do some of them after biopsy if somebody's been diagnosed with low-grade disease and we're considering just watching it. Then there are tests to determine whether or not that's a good idea or not. One of Dr. Kane's patients recently, I employed one of those tests because we're going to do active surveillance. Active surveillance is a bad idea based on that test. His risk is very high to progress. So now we know, hey, we don't watch that. So there's so many tools in the toolbox for managing prostate cancer, from the diagnostic standpoint, also to the treatment standpoint, that are available to us. But yeah, I have people who will use them. And I try to stay out there on the front line and use them as much as possible. Hey, one thing we haven't really stressed, and I wanted to say before we get off, is what the actual screening recommendations are. Can I do that really fast?
Absolutely.
You can do it slowly if you want to, but go ahead.
All right, I'm going to switch to let Mr. Jackson know I'm switching to share my screen really quickly. And he'll let me know if I can do that. And we're going to look at the National Comprehensive Cancer Network guidelines. Can y'all see my screen?
Yes.
Okay. So I like the NCCN guidelines because they're really easy to kind of follow. And so let's concentrate right here. Age 40 to 75 for patients who are high risk. High risk patients are Black or African American individuals, or those with family histories of prostate cancer. And if gene testing was done, or genetic testing was done, then those people who have the genes like BRCA1 and 2 and ATM and other genes that are associated with a more aggressive disease. So for African Americans and people with family histories in particular, start getting screened at age 40 to 75. And so that screening should be a PSA, and then they recommend doing a DRE, but they say if done. But the European guidelines state that 18% of the time you'll find a cancer in patients who don't even have an elevated PSA. So I always recommend doing the rectal exam, because we're here to find disease early, not to make people comfortable by not doing an exam. So next step is, so if the PSA is we'll say is less than 3 here in the high risk population, that's us, then you could continue to follow at 1 or 2 year intervals, but because they changed this recently, not every year now. If the PSA is less than 3, I still don't like less than 3, because 3 is the cutoff. So if somebody is less than 3, I still probably want to screen them the next year to make sure that it's not going up, because if they're right on the borderline. So PSA and rectal exam. So if their PSA is greater than 3, or they have a suspicious rectal exam, then the urologist needs to be determining whether or not they're going to do a biopsy or not. And that biopsy is probably going to be preceded by an MRI to see if they have any aggressive areas that can be targeted at biopsy. And then for people who are greater than 75, I don't like ageism. I don't like to say people shouldn't be screened after a certain age, because we have people in the Black community who live a long, long time. And so I don't make sure that they don't die of prostate cancer because we didn't screen them too. And so the NCCN says, hey, if their PSA is less than 4 and they have a normal rectal exam, then you could screen them at 1 to 2 year intervals. But if that PSA is greater than or equal to 4, or if they have an abnormal rectal exam, then they need to be evaluated for biopsy as well. So those are the NCCN guidelines for screening. And I just want to make sure that everybody knew what we're talking about: PSA and rectal exam for screening, and what ages and so on and so forth.
Thank you, Dr. Williams. As a matter of fact, I was going to mention, and I'm getting this information, by the way, off of the Prostate Health Education Network's website, when they talked about knowing for risk, knowing your risk, race, family history, aging, diet, gene changes, chemical exposure. Take the risk quiz. If you can answer yes to these: are you Black or African American? Are you a veteran? Did your father or brother have prostate cancer? Are you over the age of 50? And lastly, do you consume a high-fat diet? It's not something that we think about in terms of the association between what we eat and some of our behavioral or lifestyle habits that can contribute to our risk of a cancer diagnosis. So as you can tell from tonight's discussion, there's a lot, talking about cancer, as AJ said. To get a cancer diagnosis, you automatically think and wonder whether or not your life is about to end. But I hope that you gained some hope from tonight's discussion, because as Dr. Williams said, that early detection is the best treatment. And for those folks to first have a conversation with their loved ones and say, I had a cancer diagnosis, and then they then encourage them to go in and get the necessary screenings. So we're at the end of the show. Always enjoy having Dr. Williams to join us, and certainly happy that AJ, in his very busy schedule of advocating around the world, that he was available to join us to share his personal experience. At the end of the show, we like to give our guests an opportunity to share their final thoughts regarding tonight's topic. AJ, how about you?
Thank you for allowing me to participate with this great panel. I don't know Dr. Williams, but I know Dr. Kane. But Dr. Williams, thank you for the information. Ms. Turner, once again, thank you. Dr. Kane, I really am going to count on you and Dr. Williams to actually come and speak at one of my support groups starting in January, because the topic that Ms. Turner brought up is very important. And thank you, Jocelyn, for at least talking about an issue that men don't talk to women. The only way we get the men to the post for program, we offer food, and we get the women to come out and we give them gift cards. But if we can stop bribing Black men to come and do what they need to do automatically, and that's why the panel you got, if we can just get that information out on a regular basis, we can save lives. Thank you.
Thank you. Thank you so much, AJ. Dr. Williams?
Oh, I mean, thank you for the opportunity. And, I think I got my 2 cents in, and Mr. Merriweather, you just don't know me, but everybody that you mentioned, I've been dealing with them for probably longer than you have. I'm just in the background a whole lot. I'm on the Eye Cares Consortium. I've been working with Finn for many, many, many years. I've been a guest speakers. I was invited to the post on April for the meeting you guys had.
Yeah.
They just didn't give me enough notice. So I'm involved in a lot of stuff that you just don't even know about.
But
I
I'm
just
gonna get
make
you.
a lot of noise about it, but I'm always happy to help, though. Jocelyn and Dr. Kane can tell you that. So anyway, but I'm just glad to be able to participate.
Thank you, Dr. Williams. Dr. Kane, what are your final thoughts?
I'm commensurate with Dr. Williams. I try to stay in the background. I'm not looking for any, much like himself. He's not looking for the accolades, applause, or anything for what he does. He does a lot of things in stealth. Because even before I actually met Dr. Williams, I knew of Dr. Williams from patients that were seeing him and were very happy to have him as their physician. So it's one of those things that you just put your nose to the grind like he does, and you just do the work, and anybody else, they can take all the accolades they want to, but we get the work done within our community. The only other thing I wanted to do is I will answer someone's questions about the colonoscopy. Someone put up a colonoscopy and a question about colonoscopy, how often it should be done. I definitely want everyone to look at, depending on family history. If it's you have a significant family history, as soon as possible is the screening needs to be done. You can discuss with your primary care and your GI doc about what type of screening to be done. But usually we're looking at 45, and if there's no issues with it, every 10 years. If there's issue with it, there are certain guidelines based on what those issues are, and you need to talk to your primary care and your specialist on that. The other thing I want to make sure we do is the elephant in the room for me is that Dr. Williams said earlier, we really need to be participatory in clinical research to help not only ourselves, but our families as well, to help determine what works for us. Okay. There are a lot of research done prior to prior to the National Medical Association, the NMA. This was a group of, the Black physicians in the country, prior to us being insistent about being inclusive of clinical research and the need to do clinical research within the Black community, so that we actually know what works for us, and us not buying products or utilizing products that will not help us at all. So be participatory in clinical research. Dr. Williams has a fair amount of programs going on with that. If I can get people to at least consider it, and there are other doctors on this broadcast, and I hope that they will be a podcast, and I hope that they will be cognizant enough to hear what we're asking, to have our patients be participatory in those clinical research, especially like those that are going on in Dr. Williams' office.
Okay. Thank you, Dr. Kane. Thank you, Dr. Williams, and thank you, AJ. For the past 15, close to 20 years, I have tried to be an advocate and a champion, although a female, for men's health. And I talked a lot about it based on the health of my dad and his health issues. I know as a woman going into the doctor with my dad, I wasn't embarrassed, probably because I'm a health educator and having worked in public health for so many years. But obviously, when it's your family member, especially your parent, you take a different perspective. And, as many of us say, everyone doesn't have a loved one to go with them to the doctor. I love what AJ said, that he goes with some men to the doctor because men are embarrassed. They may not want to take a female with them. So to be a buddy, be a partner, that's so important. But the main thing that I learned from tonight's discussion is don't put your head in the sand or not share your story. Sharing your story is not telling your business. It could, in fact, save someone's life. thank you as always for tuning in to Pause for the Truth. And by all means, please subscribe to our YouTube channel so that we can continue to spread the message, spread information. And we look forward to you joining us again next week.
Welcome to Pause for the Truth. We are grateful that you joined us today and hope you've gained valuable insights on our current topic. We look forward to having you with us next time as we explore trending issues in our community and discover ways to simplify life for you and your loved ones. Our dedicated panelists and staff are committed to sharing knowledge and serving our community. But now, we need your support. Please subscribe to our YouTube channel and spread this valuable knowledge to others. Don't forget to invite your family and friends to tune in to our podcast every Tuesday at 6:30 p.m. EST. Visit our website at www.pauseforthetruth.com and show your support by liking us on Facebook, following us on Twitter, and linking with us on LinkedIn. Feel free to email us with any questions, or concerns, or show topic recommendations at info@pauseforthetruth.com. I would also like to give thanks to our behind-the-scenes technology engineer, Tyrone Jackson, owner and operator of Call Tyrone. Go to www.calltyrone.net for a complete list of services. Thank you for being a part of Pause for the Truth. Together, we can make a positive impact on our community. Good night.